Welcome. Today we're delving into a common yet often overlooked condition affecting the male reproductive system, prostate calculi, also known as prostatic stones. So, what causes these stones to form? The etiology of prostate calculi is multifactorial and often unclear. One prominent theory involves the reflux of urine into the prostatic ducts. This allows urinary salts such as calcium phosphate and calcium oxalate to precipitate and accumulate. Chronic inflammation within the prostate, often associated with prostatitis, also plays a significant role. Infection in the presence of corpora melacea, small proteinaceous bodies found in the prostate, can act as needy or starting points for stone formation. Benign prostatic hyperplasia, or BPH, can contribute by causing urinary stasis and altered drainage within the gland. Let's explore the pathophysiology. The formation of prostate calculi is a gradual process. The initial event is often the precipitation of minerals within the prostatic ducts and acini. These minerals, typically calcium-based, accumulate around organic matrices, such as degenerated cells, prostatic secretions, or corpora melacea. As the stones grow, they can obstruct prostatic ducts, leading to inflammation, infection, and further stone formation. Over time, large calculi can erode into surrounding tissues, causing pain, hematuria, and other complications. The presence of these stones also predisposes the prostate to recurrent infections, creating a vicious cycle. Understanding the epidemiology of prostate calculi is crucial. The prevalence increases with age, becoming more common in men over 50. However, it's important to note that the true prevalence is difficult to determine, as many men with prostate calculi are asymptomatic. Studies suggest a higher incidence in men with chronic prostatitis or BPH. Geographic variations in dietary habits and water mineral content may also influence the prevalence of prostate calculi. What are the signs and symptoms? Many men with prostate calculi experience no symptoms at all. However, when symptoms do occur, they can vary in severity. Common symptoms include pelvic pain or discomfort, pain with ejaculation, hematuria, a blood in the urine, painful urination, dysuria, increased urinary frequency, and a weak or intermittent urinary stream. In some cases, prostate calculi can contribute to recurrent urinary tract infections or prostatitis. Larger stones can even cause bladder outlet obstruction, leading to urinary retention. How are prostate calculi diagnosed? Diagnosis typically involves a combination of physical examination and imaging studies. A digital rectal exam or D may reveal a hard or gritty texture within the prostate. Transrectal ultrasound or TOS is a valuable tool for visualizing the prostate and detecting calculi. Rays can detect calcified stones, though smaller ones may be missed. CT scans provide a more detailed view and are useful for assessing the size, location, and number of calculi. Urinalysis is performed to rule out infection. In some cases, cystoscopy, a procedure involving the insertion of a small camera into the urethra, may be necessary. While not strictly classified into distinct types, prostate calculi are often categorized based on their size, number, and location within the prostate. They can be small and numerous, resembling sand, like grains, or large and solitary. Their location can be within the prostatic ducts, acini, or even embedded in the prostatic parenchyma. Some are predominantly calcium-based, while others may contain higher proportions of other minerals like magnesium or phosphate. These characteristics influence the choice of treatment. The treatment and management of prostate calculi depend on the severity of symptoms and the size and location of the stones. Asymptomatic patients may only require observation and regular monitoring. For symptomatic patients, treatment options include antibiotics for associated infections, alpha blockers to relax prostatic muscles and improve urinary flow, and pain relievers to manage discomfort. In cases of large or symptomatic stones, surgical intervention may be necessary. Transurethral resection of the prostate, or 2RP, can be used to remove the stones during the treatment of BPH. In rare cases, open prostatectomy may be required. Extracorporeal shockwave lithotripsy, or ESOL, a non-invasive procedure used to break up kidney stones, is sometimes used for prostate calculi, but its effectiveness is limited. Is there anything we can do to prevent prostate calculi? While complete prevention is not always possible, certain measures can reduce the risk. Maintaining adequate hydration helps to dilute urine and reduce the concentration of minerals. Prompt treatment of urinary tract infections and prostatitis is important. Dietary modifications, such as limiting calcium intake, may be considered, although this is controversial and should be discussed with a healthcare professional. Regular exercise and a healthy lifestyle can also contribute to overall prostate health. What is the prognosis and what recent research is being done? The prognosis for men with prostate calculi is generally good, particularly with appropriate treatment. However, recurrence is common, especially in individuals with chronic prostatitis or BPH. Recent research is focusing on identifying the specific factors that contribute to stone formation and developing more effective and less invasive treatment options. Studies are investigating the role of biofilms in stone formation and the potential of novel antimicrobial agents. Additionally, research is exploring the use of minimally invasive techniques, such as laser ablation, for stone removal. Continued research is essential to improve our understanding and management of prostate calculi.